Welcome to the Brave Hearts. Thank you for staying on. Un mille grazie al professore Ronco per il gentile invito. So, I've got no conflicts of interest to declare. You may ask yourself why I am here. Well, I'm coming from an institution which is reasonably well known for liver transplantation and probably more so for the treatment of acute liver failure. So we perform about 200 to 250 adults and pediatric transplants a year. However, over the last 50 years, I guess we have made a name for the treatment of this disease, which is acute liver failure, and this is what I will be predominantly talking on now. So what is the definition of acute liver failure as opposed to decompensated chronic liver disease or acute on-chronic liver failure? It's a severe liver injury, potentially reversible in nature, and with these time sets. And the definition really hasn't changed over the last 50 years. There are certain timelines involved, 6 months from the onset until hepatic dysfunction sets in. And it is a very rare disease, as you can see here. Pathophysiologically, we have got an acute insult, and it can be many things. For us in the UK, it is predominantly tablets, as in paracetamol. It could be pregnancy-related injuries, most of the time within the developing world at least, and that is obviously the parts of the world where acute liver failure is seen the most. It is due to viruses, and sometimes we can see insults relating to trauma. Usually the regenerative ability of the liver to cope with the insult is overwhelmed. However, there may be a group of patients who will find and see resolution, provided then we can keep them stable enough during the time period of regeneration. So if we're thinking about extracorporeal liver systems or devices, we want to look for something which can support the liver and extrahepatic organs until regeneration can take place. There's also something to be said about where the insult happens. You have got areas like here within the portal triad where regeneration takes place, i.e. if you had an insult there, the likelihood of regeneration is less than if it happened around here, which is usually the case with hypoxic liver insults. So again, if we could target particular molecules within those pathways to enhance the regenerative processes, we may have a winner. Acute liver failure, as you all know, is a multi-systems disease. You see on that sketch that pretty much every organ from top to toe is involved. Often patients are very acutely ill, so not only do we want to treat the end organ failure of the liver, but we need to also support other organs in the process. So what liver support devices are there? We are predominantly probably talking about detoxifying dialytic devices. The most simplest of it would be renal replacement therapy. More frequently nowadays, or in the last 20 years, the use of forms of albumin dialysis, absorptive systems, and plasma exchange, as opposed to biological systems which perform ideally hepatocyte functional capacity with synthesis of proteins apart from just detoxification. So liver perfusion devices and cell therapy I will not talk a lot about. So if we are thinking about detoxifying devices, most of them and the most frequently used ones on the market are, as you probably know, the Mars system and the Prometheus system. We are looking at dialytic devices predominantly, which either have got albumin-coated dialyzers with exogenous albumin circulating in a secondary circuit combined with dialysis. And in the system, we've also got anion exchange resins and charcoal to clean the circulated albumin of all the water-soluble and protein-bound albumin-bound toxins. A reasonably similar device in its function, the Prometheus system, where we have got no exogenous albumin, but higher cutoff of the membrane up to 250 kilodaltons, as in the endogenous albumin is actually sequestered out of the plasma and then cleared by, again, a resin as well as an anion exchanger and then recirculated. So what can these devices do, and how do we measure it? All extracorporeal circuits, by and large, when tested, did show a drop in ammonia levels. They may have an effect on bilirubin and bile acids, but all of these things are surrogate markers of liver injury. For some of the devices, again, improvement in cardiovascular performance has been shown. Again, what probably comes to play is your extracorporeal circuit, hypothermia potentially associated with that, and some degree of vasoconstricting effect. Decrease of infection, much more difficult to prove. Control of portal hypertension, no proof at all. Control of bleeding, potentially to the contrary, as I will show you in a moment. And how do we measure it? Given that in acute liver failure, we've not only got a loss of anticoagulant proteins, but also procoagulant proteins. And none of the studies really have looked at functional monitoring in that sense. And as we've said, we want to create an environment which will be conducive to regeneration. But how do we measure that? Well, Mars works, doesn't it? If you look at all these factors I've already listed, and if you looked at some of the trials or most of the trials, you will show a significant drop in those surrogate markers. As I've said before, this does come at some degree of a price, in as much as many of these patients have bleeding complications relating to thrombocytopenia. And that is not only true for the Mars system, but also for the Prometheus system, if you looked at randomized controlled trial data. If we're looking at ammonia, though, and this is some data from our old group, just looking at other forms of extracorporeal support, here hemofiltration as well as diafiltration at various ultrafiltration rates, you can see a fairly linear correlation in terms of ammonia clearance dependent on ultrafiltration rate. So your very simple, basic renal replacement therapy may actually do some of the stuff which putatively liver support devices do provide. Any data in acute liver failure? Well, there was this trial, which is called FULL-MAR. So Mars therapy in acute liver failure. You see the number of patients enrolled, 102, so a relatively large trial from a liver perspective and acute liver failure perspective, multicentric, performed in France. The main etiology of the patients was paracetamol again. However, only about a third of the patients, and it tested standard medical therapy versus the Mars device. All of these patients were listed for transplant, however, only 68 got transplanted. So the rest of them, either they got better or they got worse to a degree where they could not be transplanted anymore. This is in essence the outcome here. No difference between the standards medical therapy group versus the Mars group. I also allude you to the fact in comparing these sort of trials with each other, and I'll show you some data of another trial later, the patients were not necessarily that sick. So only about a quarter were mechanically ventilated. And if you looked here, only a minority of patients were actually receiving vasopressor agents. There was potentially some trend towards the MAS-treated patients receiving a transplant more readily than the conventional care group. The problem being, though, that most of the patients were transplanted within a very short period of time, within 8 hours. Another trial which looked at MAS in a group of patients who may not be or not as readily eligible for transplantation. This is a trial from Singapore. Diseased donor liver transplantation in these group of patients in Singapore or in the Far East is obviously much less readily available compared to Europe or the States. So if you looked at the patients who were not able to receive a transplant, 43 of those, 42 of them died with or without MAS treatment. What about biological systems? Well, this is something which isn't that new and maybe slightly unorthodox if you look at one of the first trials more than 45 years ago. So initially what happened is that people tried to use livers of animals, so xenolivers. However, although the patient did survive for a little while and did better than the animals, it ultimately obviously did not work. So biological systems, as opposed to the detoxifying systems, now use in a variety of assemblies bioreactors which have got cells in them, that is liver cells, and pretty much common to all of the devices is that there will be some form of plasma separation initially to get rid of the toxins, and then the blood will be perfusing the bioreactor or the cells where some or hopefully most of the synthetic liver function will be provided for. Very old studies or older studies, now 20 to 10 years ago, predominantly looked into the BAL device and the ELAD system. And initially at the beginning, devices looked like this. They're still fairly cumbersome in terms of their size, so we've got a fairly small ICU, as in very small bed spaces. So whenever we do things like this, which we've done in trial forms, I think now 3 times, it is actually quite difficult in terms of the space requirements. Sorry, I should go back here. So from an ELAD perspective, we've so far performed 3 randomized controlled trials in acute liver failure, I hasten to add, and we've taken part in all of those. No outcome benefit shown in the 2 earlier ones, and the 3rd one was terminated early. What are the technical difficulties? The logistics, you've just seen the size of the apparatus for various of these devices. The cell type and how the cells are arranged. Liver cells like the parenchymal structure of the organ, so not only the cell components but everything around it, and they don't tend to survive very well outside the body. You need to keep them energized, so you need to have an oxygenator and you provide some nutrition for the cells. Sometimes it's very difficult to actually culture them and keep them alive once they've gone into the bioreactor. And then there are other concerns such as toxicity concerns. Some of the cell lines use cancer cells, as I will show you in a moment, or disease transmission if you're looking at the porcine devices. So the 2 most frequently used cell lines are these here. In the ELAD system, it is well-differentiated hepatoma cell lines, which do perform some, but not all, of the synthetic liver function. And there's obviously always the concern, although there is no case reported in the literature, of malignant spread. And then we have got the xenogenic devices and hepatocytes, and many of the devices which were on the market were withdrawn because of the concerns regarding retroviral disease transmission, porcine endogenous retroviral disease, which at least in cases has been reported even if patients did not come to harm. How many cells do we need? Well, at least half a kilo, roughly. And the problem also is that, many of these cells will not survive for very long. So ideally even more than that, but you can't keep them alive. So this is the Hepat Assist device, which has been studied in a multicentric fashion in the States and Europe, and the results of that trial were presented not too long ago. So they work with primary porcine cells. Again, you've got a plasma separation device to start with, and then the plasma goes through the bioreactor. You've got a charcoal cartridge here as well to get rid of toxins, and then a dialytic component to the system at the end of it before it goes back into the patient. Unfortunately, in this randomized controlled trial of 171 patients and 20 centers, no difference in outcome, neither in the patients who had acute or subacute liver failure, nor in the ones who were suffering from primary non-function following liver transplantation. So did they all appear to be safe? From what I've already told you, there had been always concerns about bleeding in most of these patients or trials, and certainly we have seen and had concerns also with onset of DIC. There is a problem, as we've already heard from Patrick Ono early on, in terms of antimicrobial clearance, obviously also with these devices here. And the interference, or do we need to anticoagulate the device to keep it functioning? In theory, yes, but it may become very tricky to know what the device is doing and what is due to device malfunction. Is there anything else out there? Well, we have, over the last 15 years, used a lot of plasmapheresis. And maybe over the last 5 years, we've got a new interest in it. That is following a large randomized controlled trial we've performed, which was multicentric in origin. What is the basis behind it? Well, it is thought that the monocytes or the macrophages are key effectors of inflammation within liver cell death. And if there is a way of modulating that inflammatory response, maybe we can provide a milieu for regeneration and improve outcome. So that is quite nicely depicted in this next slide here. You've got hepatocyte death, and then due to Kupffer cell activation, you do get these DAMPs and toll-like receptor signaling leading to an increase in cytokines with all the negative side effects in terms of the brain, for example, encephalopathy, but also capillary leak, hemodynamic side effects. And is there potentially during this initiation, cytokine storm period and then propagation period, is there a role for plasma exchange to ameliorate this? Later on, we've got another type of monocytes who are actually quite important in terms of cell regeneration, and that is the reason why performing plasmapheresis late in the day may potentially be not beneficial. So we want to interact and interfere with this hyperstimulated early phase rather than late. And this is a trial, so high volume plasmapheresis, meaning that we're trying to exchange about 15% of the plasma volume in order to remove toxins from multiple body compartments, not only the plasma itself, which obviously means that you're going to use a lot of plasma on 3 consecutive days and very early on. So in the trial, a mean number of 2.4 exchanges were performed. The patients were fairly well matched, as you can see. The majority of them had paracetamol-induced acute liver failure. I told you early on, if you're comparing trials, it's always important to know if the patients are alike. So in this trial, certainly a lot of patients required vasopressors compared to the Fulmar trial, and a lot of patients, or pretty much all of them, were ventilated. So you're not comparing like to like. This, in essence, is the outcome. So there was a significant difference in outcome in the patients who did not get transplanted, the ones who had contraindications for listing for transplantation and the ones who did not get transplanted because they got better or delisted. So we conclude that high-volume plasmapheresis can improve transplant-free survival, and that was statistically significant. There was also a significant reduction in end organ, non-hepatic end organ failure, and it was a relatively cheap treatment to use. I will skip about over the last 5 or 6 slides I've got. This is just, and apologies, it is very small print, to show you that out of these trials, FUMA, Helios, and Relief trials, so some of them in acute on chronic liver failure, but in acute liver failure, the only trial which has shown any significant outcome benefit was the high-volume plasmapheresis trial. I will skip over the ECMO bit because we're going to hear a talk on ECMO. So I conclude, ladies and gentlemen, that ALF is a very rare disease with still a reasonably high mortality, although that has dropped of late. The transplant-free survival has certainly improved from somewhere around 20% to nowadays 45 to 50%. Despite having extracorporeal devices around for more than 3 decades, we haven't really found the holy grail yet. We think that high-volume plasmapheresis may play a role in bridging patients to transplant or potentially in a subgroup of patients improving survival. I think where the meat on the bone lies is probably in the future, rather than these cumbersome big devices, cell-based techniques like hepatocyte transplantation or mesenchymal stem cells. And I think I'm going to leave it with there. Thank you very much.